All right, so my name is Andrew Pleasant, and yes, I am in fact a member of the Global Working Group on Health Literacy as part of IUHPE. And I want to thank everybody for joining us, and others will continue to join us. But to start it off, I would be remiss to not mention that the reason we are here is to celebrate and honor the 70th anniversary of the International Union for Health Promotion and Education. And in so saying that, I want to point out that this is an organization that has existed longer than I personally have been alive. And I want to point out the word union because it really means something in terms of how an organization is managed and directed. You know, the speakers who I'll introduce next and I are all friends, and thus we have a union, but the union extends beyond even people in IUHPE who I haven't known. And we're all working towards improving people's health and well-being. And you should feel special about being part of this. Let's go to the next slide. So here's your speakers for the day. I will go left to right. That's me first, Andrew Pleasant. I'm in the United States, in the state of America, so that means that I get to say good morning, but to some of you it's good afternoon, and to some of you it's good evening. Whatever time it is in your time zone, make it good. So next to me is Professor Gill Rowlands. Gill is a general practitioner and a professor in the Population Health Sciences Institute at Newcastle University in London. Her main research interests are in the area of health inequities, particularly the role of health literacy in health and the role of general practitioners in identifying and addressing the problems faced by patients with lower health literacy. And I am going to try to say this all quickly to get out of everybody else's way, because all I am is the moderator. So my job is to get out of the way. Next to Gill is Professor Diane Levin-Zamir. Diane is the National Director at the Department of Health, Education and Promotion at Claylit Health Services, as well as Associate Professor at the University of Haifa, School of Public Health in Israel. Diane specializes in action research and health promotion and community primary care, hospital and media settings, media health literacy, and measuring health literacy. Next to Diane, at the top right corner there, is Dr. Susie Sykes. Susie is an associate professor in public health in the Department of Allied Health at the London South Bank University. Her professional background is in public health and health promotion, and she has particular interests in community development, health policy, and health literacy. And below Susie there, not to indicate anything other than that's how the graphic designer laid it out, is Dr. Orkan Okan. Orkan is a member of the Faculty of Educational Science at Bielefeld University in Germany. He is interested in research on educational and health-related socialization processes, health promotion and primary prevention in children and youth, health literacy and mental health literacy, as well as inequality and disparities-related questions, as well as methods of childhood studies. So that's us. That's who you're going to be hearing from. Let's go to the next slide, please. All right, so why health literacy is relevant. Health literacy has been called one of, if not the strongest determinants of health. So it is clearly a core issue for our union that we are all a part of, right? It's also one of the strongest tools to address non-communicable diseases, prevention and control. And of course, as we're learning now with COVID, it's also one of the strongest tools to address communicable disease. It underpins health promotion in all areas. And then the one item that I'll add to this slide is health literacy is also how we connect health to environmental quality, because if you don't have a healthy environment, you don't have healthy people. Next slide. Sorry. Wrong way. There you go. So today, right, we're going to talk about the foundations, the basic ideas, a work plan. We'll introduce the position paper on health literacy for IUHPE. We will also address COVID as we go through this, and there will be question time at the end of the session, which I will apparently figure out who should answer your questions. But to have that challenge, you all need to submit questions, and you can do that in the chat box as we go along. All right, I think I've covered that. Go ahead, next slide. And that's it for me. Jill, you are on.
Thank you very much, Andrew. So hi, everybody, and it's such a pleasure and an honor to be able to talk with you today and to tell you about just some of the exciting stuff that the Global Working Group on health literacy is involved with. I'd like to start by thanking Diane Levin-Zamir, that you're going to hear from a bit later today, who was the founding chair of this Global Working Group and who's done so much to make it such a vibrant and exciting group. So thank you, Diane. It's an honor to have the chance of following you on this. So I'm going to talk a bit about how we started and what we're aiming to do, the sort of overarching aims of the group, before I pass on to my colleagues who are going to give you some more specific examples. We've been going for 14 years, is that my maths up to this? And it all started off in Vancouver at the Vancouver meeting, and was officially established by resolution of the IUHPE in 2010 in Geneva. And we've got active members from all the continents around the globe, with the sole exception of Antarctica, where there isn't anybody but a few scientists. But all the other continents, we have active membership. So we're truly a global group, and that makes it exciting and interesting, and means that we can share so much and do so much more together than we could if we were working on our own. So our overarching mission is to initiate and support research, policy and action on health literacy. And we're not just doing it for the sake of it, we're doing it because we see health literacy as a way to reduce disparities, to reduce inequalities in health promotion, in supporting people to feel and be well, for sustainable development, and to the pursuit of equity, both within countries, and I live and work in a country that sadly has huge inequalities, but also between countries, and we're seeing that at the moment, as we are going through COVID, and health literacy is a way to try and address some of those inequalities and inequities. We obviously work locally in our localities, in our communities, in our countries, but we also work globally. We'd be delighted if any of you are enthused after today for you to come and join us, and that's where you find us on the IUHPE website. Okay, so these are what our aims are, and I'm not going to go through this word for word, but we try and address the breadth of health literacy. We're around developing the academic discipline of health literacy, making sure that we all understand the theory and that we're advancing the theory as our understanding develops. We're very interested in producing evidence, and also not just presenting problems, but presenting solutions, so that our colleagues in policy can actually change things and make a difference. And also so that those of us who are in face-to-face practice with patients, with clients, can actually change things. We're very focused on sharing learning across the group, and for group members to share that learning with their colleagues who might be outside the group. Make sure that we keep making the case for health literacy as a critical and a social determinant of health at all levels. Make sure we're building the evidence base. So those of us who are researchers are responsible for doing that. Making sure that we think about who the relevant stakeholders are so that we can work with them. And that, of course, very importantly includes our partner global working groups within the IUHPE. And then to pull together an action plan that makes sure we can not just talk the talk, but we can walk the walk and demonstrate some outcomes. And as I say, you'll be hearing about some of those practical outcomes a bit later. So over these last 14 years, what's changed? Well, a lot's changed. When we first started thinking about health literacy, it was seen very much as a risk factor that clinicians like me would identify in patients that had to be mitigated and overcome. Increasingly now, we're moving to what's we call a universal precautions approach, which is rather than identifying people with health literacy needs and focusing on them, that actually we develop systems that are accessible and useful to everybody, regardless of their health literacy level. We're also moving away from focusing on individual people and identifying them as a problem to be overcome, to focusing on the system and how the system can work better for everybody. So now I'm going to hand over to my colleague, Susie Sykes, who's our secretary. So Susie, just tell me when you're ready for me to move the slides on.
Yeah, that's fine. Thanks, Gill. Okay, thank you, Gill. I'm only going to speak for a couple of minutes, but we did want to just give you a flavour of how the aims of the Global Working Group that Gill's just outlined have translated into activities over the last year, before Diane and then Orkan go on to talk in more detail about a couple of specific areas of work. So part of our work over the last year has been to review our internal structure, membership and governance processes. So with a leadership group that meets regularly, and then a task-focused core group, both of which feed into a wider working group, we're able to ensure that there's communication channels and also develop an agreed work plan, which we have in place with nominated leads for actioning specific work stream areas around policy, research, communications and governance. So through this structure, clusters of our members are able to contribute to our work plan through their particular area of interest. And as a very active working group, as Gill said, we continue to grow our membership and do look for opportunities to do this. So do contact us with any thoughts on that. Important to us is ensuring that we link across the IUHPE working groups and committees, as Gill mentioned in one of our aims. And in doing this, we recognise that the commonly held principles of health promotion that thread across all of the working groups. And we work to create a synergy and avoid a kind of silo working, recognising the overlapping of themes. So there are many examples of how we do this, and we have a particularly close working relationship with the Global Working Group on salutogenesis and also on health promotion settings. And currently, for example, we're working with the North American Regional Office on a theme that we've identified as an overlapping theme of public trust, and using this to work jointly to build into a two-phase sub-plenary session proposal for the IUHPE conference in 2022. So fostering collaborations externally and building partnerships with other organisations focused on advancing health literacy is key, I think, and expanding the network of networks, if you like, allows for the growing evidence base around health literacy to inform policy, future research, as well as, importantly, practice. And many of our members are part of initiatives such as MPOL, the Action Network on Measuring Population and Organisational Health Literacy. And such collaborations are really important in pursuing a research agenda that provides data that are comparable globally, and therefore far more useful and impactful. So many of our members were involved, for example, in the very early days of the COVID Health Literacy Network, which currently has over 100 members from 50 countries represented, and which has been really key in coordinating a global approach to health literacy research in light of COVID-19. And Orkan's going to talk in more detail about this work in a moment. And finally, the working partnerships that are generated through this working group ultimately seek to advance the knowledge and understanding of health literacy as we work together on joint research projects, share ideas for advancement and promote debate through our joint publications and conferences. And this has been particularly important over the last year as we seek to ensure the understandings of health literacy are really embedded in the pandemic response. So, for example, a paper recently published in Global Health Promotion by some of our working group members presented 5 case studies from across the globe, exemplifying some of the real world action and challenges for health promotion intervention, policy and research during the pandemic, and illustrating the pivotal role that the development of health literacy in practice and in research played within each case. And an important role for the working group in advancing knowledge is to capture, present and share, disseminate the state of the art in relation to health literacy through the working group's published position statement on health literacy. And as an activity that we've been working on recently, I'm going to hand over now to Diane and let her pick up on this as she talks us through the recent developments we've made to this working document.
Lovely, thank you, Susie. So Diane, I'll stop sharing now.
Okay, thanks so much. And I will share now. Okay. Can you see my slides? Hello, everybody. Can you see my slides? Yes? Okay. Well, thanks, Susie, and thanks for the introduction, Andrew and Gill, for giving us the orientation of the group. It's such a pleasure to be here with all of you. I see so many colleagues in the Zoom, in the webinar now from all different parts of the globe. So it's great to see you. And again, thank you all for all the mutual work that we've been doing all these years together, and we still will to come. So I just wanted to share with you one of the special strategic activities that we have from the group that is for a global reach. Before doing so, I want to say happy birthday to the IUHPE, 70 years old. That's a tremendous accomplishment, and we've got lots of decades to go together, hopefully, to keep making an impact on health literacy and health promotion globally. So it's wonderful to have this celebration, and congratulations. So what I wanted to share with you was a specific strategic activity that we have that came out of a need. We're all involved in health promotion, and we all know how important it is to have tools for advocacy. And we have been receiving more and more questions and being approached. The IUHPE was being approached by journalists and other interested groups to find out more about health literacy. So what we did was that we developed a position statement on health literacy to be able to promote the action areas that were mentioned before, that Susie mentioned, and that we would like to see happen across the board in health promotion and in public health and in health in general. So we developed this statement so that it would be a tool to be able to influence policy. We call it the position statement on health literacy, a practical vision for a health literate world. And I would like to just mention to you the action areas. I think somebody needs to be on mute. Okay, thank you. So I'm going to just briefly walk you through the action areas. I invite you to go onto the website of the IUHPE, to go into the webpage of the Global Working Group on Health Literacy. You can see the statement there, and also the statement in the advocacy tabs of the IUHPE website. And you'll be able to see what our vision is and how it's developing into what we would like to see more in the future as a result of what happened when we started to publish this. So really quickly, the process was a very participatory process. We wanted to have a guiding statement for health literacy, and we had consulted not only our large group, our wider group of health literacy, which we're very lucky to have 60, 70, 80 people on our wider group. Then you're all invited to join. But we also looked outside the working group to see the different perspectives on health literacy. What are the action areas that need to be taken, and what needs to be improved in health via using health literacy as a vehicle. It was ratified by the IUHPE Executive Board in May 2018, and we are in the process of updating. So I'll just give you the action areas really briefly. I won't go into them. In any detail, but I will be just mentioning them very briefly, and we'll be able to go into them more when we want to have any discussion about them. So firstly, we'd like to promote a systems approach to health literacy, not only a systems approach to health promotion, but we also have a systems approach to health literacy. So all of you know the socio-ecological model. So if you can just imagine what we would see at different levels, we also want to promote it in health literacy. We want to ensure the inclusion of health literacy in global, international, and national and regional policies and strategies for health promotion and social determinants of health. We need to ensure the inclusion of health literacy because we know, we've seen, as Andrew mentioned, that it is so, it can and it does have an influence on policies and health promoting policies. So we want to make sure that's in. So I'm going to continue. We want to recognize that health literacy is content and context specific across the lifespan. So we have two important points here. We need to look at the content in as far as context. When one part of the world is not the same as the other, one setting is not the same as the other. And so we know that it's relative to cultures and relative to societies, and also across the lifespan. It's never too early to influence health literacy. And of course, we want to see it go through to the latest possible age. And we know it's important across the lifespan. It's modifiable at any age. Plus, we want to make sure that we are influencing all the institutions and all the all these who will can be health literacy appropriate. So we want to recognize that health literacy is modifiable in response to appropriate evidence-based interventions. Much of it is based on health education, but not only. We know that environmental influence and other social determinants and physical determinants of health. We want to emphasize that health literacy intervention should be a people and community-based process for empowerment. And of course, we all know that, but we put this in it's a very strong part of our statement because it's not health literacy for health literacy's sake. We want to make sure that we are empowering the community, empowering individuals, empowering policymakers to make the best decisions. We want to make sure that we're looking at resources and promoting the allocation of resources to make sure that we can have the best possible resource and research to make sure we have an evidence base, because we want to demonstrate how the actions that I've mentioned are really influencing health literacy, and reducing inequalities. Equity is one of our most important strategic goals for promoting health literacy. We almost finished, but we want to build capacity and sharing knowledge for workforce development, applying an intersectoral approach. Health literacy doesn't belong to one discipline or one sector. We want to see it as cross-cutting. We want to be able to implement, and we want to be able to promote health literacy skills for all the health professionals, for anybody who's working in a field. The health literacy can be part of what they do. So we want to share knowledge, we want to have training, we want to make sure that's part of any of the training that we're involved in. And finally, we want to identify the relevant stakeholders for collaborative health literacy. We want to make sure that we're joining and partnering with all who we can do together. We know that we can only do this together. So whether it's other health organizations, or whether it's coming from any other sector, we need to identify them and work together to influence and promote health literacy. So in conclusion, we just highlight the role of health literacy as a cross-cutting issue. We're looking at it definitely for advancing global health. And the way in which the policy statement is disseminated is, firstly, it was published in the Global Health Promotion Journal in December 2018. It feels like a long time ago because so much has happened in the world since then. It's posted on the webpage. We discuss it in world and regional conferences and local conferences. It's been translated to different languages. We use it for teaching, for training, for capacity building. We allocate health literacy along with collaborative partners. And we call it a living document because we want to make sure that it's periodically updated. And this is an opportunity for me to tell you that we are working on an update now because so much has happened, particularly in the past year. We've learned so much from COVID, whether it's infodemics or our community development, or how we work, how if we're not careful, we will be promoting disparities instead of closing disparities. We've learned so much. So we want to feed that into the position paper. So we are updating it. So stay tuned and keep in touch so that you can see how this is developing and use it for your purpose. So thanks so much. And handing it over now to Orkan. I'll stop sharing and Orkan, over to you.
Thank you so much, Diane. I've just posted a comment. Please read it and post your own comments and questions from now on. We will address them later on in the Q&A section. I'm going to share my screen now, and I hope that you will be able to see it. Diane, can you give me a sign if see it?
Yes, we can see it. You could just open it up to full view.
Yeah, is it full view now?
Perfect.
Okay, great. So thank you so much. So I will talk about a study, a longitudinal trend study on health literacy in relation to COVID-19 that we have conducted last year called HLS COVID-19. But the first things first, why is health literacy so important in the time of COVID-19? This is because through health literacy, people are being enabled to participate in risk and health communication, which is really important during the pandemic. They are also being empowered to acquire and use knowledge about the coronavirus and COVID-19. They are being enabled to understand and apply the messages in relation to the behavioral and protective recommendations that are given by health authorities and communicated through media channels such as social and physical distancing, wearing a mask, washing hands, etc. And also health literacy helps people to access and evaluate online information, which is specifically important given the fact that there are so many dis and misinformations, conspiracy theories, etc. out there, and all of which is being accelerated by the infodemic. And I want to dig into the infodemic a bit. Infodemic is not a new concept. It is out there since 2003, and it was coined by Rodkov during the first SARS-CoV outbreak in China back then. But early on next year, WHO declared that the pandemic, the COVID-19 pandemic, is in fact accompanied by this infodemic. And in this context, infodemic is short for information epidemic and means that there is an overabundance of information attached to the COVID pandemic that travels even faster as the disease and the virus itself. And this comes with both accurate, so correct, right information, and not so right information, with disinformation, fake news, conspiracy theories, etc., all of which creating a very, very complex information environment, overwhelming people, making information tasks difficult. And of course, we have to ask in this context, what is the role of health literacy and what does it mean to have health literacy problems when being confronted with so many information, many of which are wrong? And for example, there was a study in Germany on the infodemic conducted by the Vodafone Foundation in children and adolescents, and they reported that they in fact encounter lots of fake news on the internet and social media. So these channels, they travel a lot through, they use a lot on coronavirus, and they stated that they would wish that this topic of fake information and health literacy is being addressed in school. But in fact, at the moment, at least in Germany, it is not addressed in school, altogether pointing towards the need to address health literacy not only in relation to COVID, but in relation to general crisis situations. So here are some background information on the study that I will talk about today. This is a cooperation between Bielefeld University, Hertie School in Berlin, and our partners in Austria, Public Health Austria, and Switzerland, Curium Foundation. We have conducted this study at 3 measurement points last year in spring, autumn, and winter in the German-speaking countries, and a total of 10,147 participants participated in this study. The study is representative for internet users regarding age, sex, income, education, and region, and the participants were 16 years and older. The questionnaire and the scales we used, you can see here, we have, of course, used sociodemographics, questions on health status, about fears and worries and vaccination, but today I will only talk about health literacy and information behavior. So basically you will be seeing insights into these 2 scales. And another very important information for you to know before seeing the results is this. What you see here is the Google trend analysis, and the circles here represent the peaks of online searches of people in Germany, Switzerland, and Austria on coronavirus and COVID-19. And they fall either right into or right after our data collection phases. And this is insofar important because we are asking about their health-related information skills on coronavirus, and our respondents engaged heavily with information on coronavirus, which may affect their skills and their knowledge and also their perception. What you see here are the general results on health literacy over 3 measurement points. I have highlighted the German results here, measurement point 1, 2, and 3. And what you can see here is 3 levels of health literacy: sufficient, problematic, and inadequate, while you can also combine problematic and inadequate to limited health literacy. And what you see is that in the first measurement point, half of the population had limited health literacy, whereas the other, of course, part of the population had high levels of health literacy in relation to coronavirus. But this significantly changed over the course of the year. Already in the second measurement point, there was an increase of 15% of people stating to have sufficient level of health literacy, and this is only slightly decreasing between measurement point 2 and measurement point 3. And what you can also see here is that generally the mean scores in all 4 dimensions of the health literacy model, find, understand, apprise, and apply information, is generally high. But in fact, the most challenging information tasks are related to appraising information, which you can see here. And the most different tasks for people to undertake in this context was evaluating the reliability of online media information, and then using this information to inform their own health behavior in relation to COVID-19 protection. And this is the results that we see also in our global survey on digital health literacy in university students, where the university students generally report a very high level of health literacy, but they have particular difficulties with these 2 tasks. And when you look on other health literacy surveys conducted prior to the COVID-19 pandemic, the population, the respondents there also report that these are the most difficult tasks to undertake. And before I move on focusing on this gray area, I just want to give you some insights to the other scales. We found, for example, that people with lower corona-specific health literacy in our study were also less likely to engage with physical distancing and all the other protective behaviors. They had more often doubt about the effectiveness of the recommended behaviors on preventing against an infection. And they also had more often negative attitudes towards vaccination. They had negative vaccination beliefs and also a higher level of vaccination hesitancy. They were less concerned that they or a family member might get infected with the coronavirus, and so on. So you can see there is a clear association between lower levels of corona-specific health literacy and several health outcomes. Okay, so what you see here is a very interesting figure because this shows the sources where people inform themselves about coronavirus at measurement point 2 and 3 of our study. And as you can clearly see, the most frequently used information source here is the television and not the internet or anything else. And we partly think that it is because in Germany we have a public broadcasting system that is also being supported by the government, lots of channels, 24/7 broadcasting about coronavirus, and many people turned to it because it was very reliable and provided valid, accurate information on daily basis. And you can see, for example, here at measurement point 2, people turn to health authorities only with a percentage of 12.8%, but already at measurement point 3, you can see that there is a more than double increase in people's turning to health authorities. And what you can also see here is that adolescents and young adults more often seek their information on coronavirus on internet or other social media channels. So this is just where they search for information. And when we contextualize this now with the trust that they have towards these different sources, you can see that in fact it is health professionals and health authorities that people trust most, followed by internet, TV, and radio. And you can see at the bottom is social media and messenger apps such as WhatsApp and Telegram. So this is a figure about the frequency of people searching for coronavirus information, and we asked them if they would search now more often for health information than before the pandemic. And as you can see here, that at T2, almost 50% of the population responded that they, because of coronavirus, they are now searching much more health information than before. There is a slight decrease between measurement point 2 and 3, but it is 40% anyway. But you can also see that there is a significant number of people stating that they would now search less frequent on health information. This is also important to know. It can be that it is too much for them, that they are that they feel too much worried, that they're too confused or whatsoever, and they decided not to engage with health information that much. On the right-hand side, you can see that across measurement points in wave 2 and 3 and across all countries, higher levels of health literacy were positively correlated with people seeking more frequent for health information. And except gender, you can see associations with all social demographic variables, age, income, education, and having children. And here you see figure about people's people being informed about the coronavirus, and we asked them, how well do you feel informed about the coronavirus? And you can see that at all measurement points, people stated that they would, I mean, almost 90, even more than 90%, that they either are feeling very well or well informed. But you can see there is approximately 10% of respondents across measurement points feeling either poor or very poorly informed. And when you look at this figure, you can see that higher levels of health literacy were positively correlated with being better informed. So you can see there is a clear association between the levels of health literacy and how far someone feels informed or not. And this is a figure about the confusion that people feel when it comes to the amount of coronavirus information available on all media channels. And the results that we have generated here are totally different from those that I've shown you on the other slide, because here you see that at all measurement points, more than half of the population, this is the orange and the red circle, feel confused about the amount of coronavirus information available. And contextualizing this with the ongoing infodemic shows us how relevant and what kind of an impact this infodemic can have on people. And you can also see here on the right-hand side that higher levels of health literacy were positively correlated with being less informed. So people who had higher levels of health literacy, this is the green areas, they were also less confused. So, and this is my summary and conclusion slide. So what we could see last year is, I mean, we already knew that health literacy is very, very important in context of non-communicable disease, but now we also learned that health literacy is a very, very important concept and tool in context of communicable disease. And we could also see that COVID-19 led to a significant acceleration of online information seeking. That was the graph that I showed you on Google Trend Analysis, but also the results from our study. And what we could also see is, and this is a very surprising result, when you remember the many green circles that I've shown you at the 3 measurement points on the levels of health literacy, that a high proportion of the population in the German-speaking countries have high levels of health literacy. And this is a different results when compared to other studies on generic health literacy, for example, generated through the HLS survey, now being generated by MPOL, where people have much lower levels of health literacy. And we think this is because there is a different health communication strategy ongoing, a 24/7 health communication strategy on all media channels affecting everybody. Health information provided in relation to COVID-19 is often very easy to find, very easy to understand. It is also very practicable. Think about hand washing, physical distancing. These are things people can easily apply in their own everyday life. And this is also the reason why they feel more comfortable and more competent in relation to health literacy. But we could also see that in the first year of the pandemic, 10% of the population, and in Germany we have like about 80 million inhabitants, and 10% of them, which is 8 million, they feel only poorly informed, and 59 to 55% felt even confused about the amount of COVID information. Right, so a way forward in this context, the thing that we learned from our study is that the kind of health communication strategy was implemented, both the organization, the methodology, the application, but also the content with the simple messages could be a way forward when it comes to health literacy interventions, that we use these principles that have been used here in the past year and are still being used as key principles in designing for future interventions. And also, since this is something that not the individual has done, but the system, the organizations and the decision makers in the background, this also points towards the need to address organizational health literacy, so system-related health literacy, you know, all the relational concept of health literacy, where personal abilities have to meet the complexities of a system. And here we have an example that it is a very useful and effective strategy to address these organizational aspects, making it much more easy for people to understand information and also to use it, and eventually making more use of their health literacy. Thank you very much. I will now give over to Diane again.
Andrew, I think.
Yeah, Andrew, you're on mute. Sorry, thanks, Jill.
So it's over to you for some of the questions.
Andrew, do you want to take yourself off of mute, please?
Oh, lots of feedback.
Yeah. Sorry. I had to switch computers, so I had two on at the same time. Sorry. So thank you all, Susie, Jill, Orkan, Diane, for your presentations. We do have a few questions. I will start, if I can get my computer to scroll back up. Well, the first one I'll just remember. It was really based on, Diane, your comments, but it's kind of asking all of us to talk some more about health literacy presentations around the world can differ. And I think we all probably have an answer to this. I'll briefly start with one of my favorite examples, which is work that I and my colleagues did in Peru that we called Theater for Health. And it was based on the earlier work of Augusto Boal from Brazil, whose work was based on some pretty strong theory also from Brazil about education and literacy. And you can all look that up online. But basically what we did was every week we presented a live theater in the community to address health issues that was moderated by an individual who's both an MD and an MPH. And we changed the story weekly based on the input from the audience, who we brought up on stage very often to tell us about their lives. And it went on for, what was it, 8 weeks. And in the end, one of the things we'd really learned to focus on based on the audience input was household hygiene, which was great because luckily we had taken actual samples from people's kitchens before we started. And then we, of course, did it at post, and we found that live theater interaction process made a significant difference in the level of various contaminants within the cooking areas in all of this two adjoining shanty towns. So that worked. You don't see it that often, but it worked. I'm sure others of you have similar examples. So go ahead and jump in with them. I mean, Orkan, we heard yours. Diane, Jill, examples of health literacy interventions in communities from around the world?
Hi, this is Diane. I can be very brief because I'll try to be very brief because I could go on and on. But I think we're looking. Hello, can you hear me?
Yes.
Can you not hear me again?
We can hear you, Andrew.
We can hear you, Andrew.
Oh, I can't hear you. Interesting.
Yeah, Diane. Yeah.
Okay.
My computer's definitely acting up.
Yeah.
Okay, so I'll just briefly just say that, bring into the conversation, in addition to what Andrew mentioned, and also highlighting what Andrew mentioned, we bring in cultural appropriateness in, because we've been doing so much work and we still need to do more on the ground level. For example, the cultural liaisons we have in primary care to liaison with immigrant communities, with refugee communities, to make sure they're able to navigate the health system, to understand the health system, to help them to continue a lifestyle that's appropriate for them, but also help them understand the new surroundings, and also be a bridge between the healthcare system and their community. So this is just one example. The whole issue of digital interventions now, we're working very hard all together, many of us in health literacy, and making digital interventions to be appropriate and to be able to help people access and actually overcome some of the barriers, the communication barriers that we have in other areas. For example, from one-to-one or personal or frontal, we're using digital systems now to help translate, to help liaison to help make information more accessible, more appropriate, and more understandable. So there's, and we're working with communities to help them develop their own digital interventions. So I think we're combining some of the basic health promotion, health education methodology that we all know, but also with innovation. And I think that's the exciting part of what we have now. And I think the research is promoting our doing more and more and to see what the outcomes are. So I'll stop there. Thanks.
And I would just, I don't want to take over the conversation. It'd be good to hear some of the other questions, but just one of the things that I think is so exciting about health literacy is the fact that something can be done about it. And there are exciting examples from all over the world where individuals, where communities have been supported to develop skills, and those have been helpful for them, not only in terms of health and having the choice to be healthy and to reduce their risk of disease, but also that there's something in there about transferable skills. And so that skills that you develop in the arena of health, actually then you can transfer to managing your money, you could transfer to digital skills, etc., etc. So that there's and I know that Andrew's done a huge amount of work on this. The literacies, if you look at literacies in a sort of holistic sense, there is something very exciting here about transferable skills. Health is a really good hook for that because everybody wants to be healthier, but there's so much exciting stuff going on around building health literacy skills and all the impact that has for people and communities.
Yes, thank you both. My audio is back, my video is gone. It's just one of those days. The next question, Orkan, is really for you. It's what are the specific questions and algorithms to come to those scores of limited health literacy that you told us about? How did you measure it?
Yes, the questionnaire is available. We have published it. I can later post the link to it. It contains of 22 questions based on the European Health Literacy Survey Questionnaire Q47, which we have shortened and on the item level have adapted to COVID-19 information, but it still reflects the model of finding, understanding, appraising, and using information. And the cutoffs that we created to differentiate between the different health literacy levels was also taken by the original studies. So we created a mean score and then from 0 to 3, and then we did a cutoff at lower than 2.5, which was inadequate health literacy. Between 2.5 and 3 was problematic health literacy, and everything above 3 was sufficient health literacy. And when you dichotomize it, then you combine the first two to limited health literacy and the sufficient one to high health literacy.
Okay, thank you. Someone else also wanted to make sure that you posted a link to your publication. So please either do that in the chat box or
yeah, I will just check it out on the internet and post it here in the box.
Fair enough. We have a comment from Stefan Vandenbroek, who said, we also found in a Belgium survey that 80% of the population still, in parentheses, rely on TV and newspaper to find info on COVID-19, but more than 25% use social media as a prime source. This is a group that may be more prone to biased information reinforced by echo chamber effects. Well, I live in the US, so I can certainly agree with your conclusion there. Stefan, when you think of the political climate here these days. The next is a question from Mark, I believe it's Bacher, but I might be saying that incorrectly. Could it be that people seek for health information less often because they are more often informed actively through different channels, so they can be passive in receiving health information, which is an interesting two-sided way to look at this issue. Do any of you have a specific reply to that? Diane, Gill, Susie,
Could you
Orkan?
repeat the question? Could you repeat
Sure.
it one more time? Thank you.
It's a tricky one, but it's interesting. Could it be that people seek for health information less often because they are more often informed actively through different channels, so they can be passive in receiving information?
I can answer that, just some of our experience. Some of you may know the initiative Ask Me 3, which is an initiative that began in the United States, and we also adopted it in Israel. And we had people who are encouraged to ask questions from their providers. What is my health problem? What should I do and why is it important? And when we study that in Israel, we noticed that in some of our communities, people would say, we don't have to ask the questions because our staff is, our health providers are forthcoming with us, which is a really great, surprising and pleasantly surprising answer. So it could be that when we have proactive health information sources, whether they're personal, whether they're media, or whatever, people may seek them less, but may be attentive to them more because they've been seeking it, they're used to it, and they wait to hear from it. So I don't know if it's passive or active. Maybe there's a balance between them. Maybe if we've been able to realize and achieve public trust, and people maybe will trust that when there's information that they need to know, the people who are their reliable sources will get it to them. So I think it's an interesting question, and this is just different. These are different lenses of the answer to your question. So thank you for your question.
Go on, you first, Susie.
I just wanted to add to that, that this really flags up the importance, I think, of increasing and advancing our understanding of e-health literacy, because as people interact and have such daily relationships with different social media platforms, that is where we see them in spaces where they may potentially be passively consuming a certain type of information. And it just pointed me to the question from Thomas around, should we be using social media as a health literacy intervention, given what Okan said about trust and social media? And I just wanted to kind of push the point really that we're at the very early days of understanding how health literacy operates within social media platforms and the importance of advancing that kind of research agenda. So just reflecting on a piece of research that we did last year around people's interaction with e-health literacy in the pursuit of fertility information, what we found was a really complex navigation of different sources of information in the processing of information. So between social media groups, but also websites and health professionals. So there's a very complex interaction and processes going on that we still need to understand more of so that we can build a more useful e-health literacy intervention for today's world, really.
So there's a couple more comments and questions on basically this point. I think what they all also point out that we haven't talked about directly is the problem of measurement in the field of health literacy. We have a lot of subjective self-report measures, but that's not the same thing as an objective measure that actually, for example, tracks someone's real use versus just say, how much do you use social media? And they say, oh, very often or very little. And it's the same for health status, and it's the same for the concept of health literacy in general. We have some more work to do there, and that's makes it really hard to really completely answer some of these questions, because we don't know that people really told us the truth. They just told us what they think we want to hear a lot. So we have to be careful. Let's see what's next. We're actually 1 minute short of when we're supposed to end. Orkan, great infodemic summary. People are responding very positive to that. Stefan, a Belgian study, I mentioned that. Is there any published research outcomes yet about health literacy and vaccination hesitancy? I'm sure there is, but I can't think of one right off the top of my head. Do any of you?
Yes, there's research that's done by Scott Ratson and the CDC and the WHO on health and there's lots of, but we're also creating the evidence now. I'm proud to say from Israel, we did not such a poor job in getting everybody vaccinated. We learned that using health literacy tools, using health promotion tools, using cultural appropriateness is a really important vehicle for doing something that's really basic in public health, which is vaccination. So again, we talked about health literacy and health promotions cross-cutting, another case in point.
Yep. All right. Well,
can I add something? There is
sure.
One study posted in the chat box on health literacy and hesitancy, and I know that in the MPOL network this has also been assessed, and in our survey and in another survey that we're currently doing in schools, we are also assessing that and preparing the publications, and we have one report in English where we also discuss this issue of hesitancy based on the results that I presented you. You can download it on the university homepage.
Indeed. Diane posted a reminder of the Global Health Literacy Summit, which everyone should pay attention to, and I believe that is our time. But I want to say that it's really nice to see, excuse me, people I know and have worked with around the world who came and joined us. I truly appreciate that you all took the time, and I hope you found this very helpful. So with that, I will wish you adieu.
Thanks, Andrew. Thanks, everybody. Stay well.
Bye, everyone. Thanks so much for joining. Really appreciated.
Thank you.